I'm going to introduce Dr. Gholam Berenji. He's a very close friend of the Canadian Association of Nuclear Medicine. We've had him lecture before, and we see him at the meetings. He's a clinical professor of radiology at the UCLA David Geffen School of Medicine. And he has been, his main focus of research for the last decade or even more has been on prostate cancer and the stuff we're going to hear about today. So he has a lot of experience with this particular tracer that we're hopefully going to see approved in Canada in the not too distant future. And he's told me that he's got a potpourri of cases. So I think it's very, very pertinent for what we're going on. And so without further ado, I'll ask Dr. Berenji to take the floor and lead us on.
Well, good afternoon. Everybody can hear me well. So we saved the best for last, I guess. That's and I see everybody's here. Thank you for coming. I would like to thank the CANM and my good friend Jean-Luc Urban for inviting me. This is my third meeting in person, and I can say this is probably the best so far. I've been very well organized. I want to thank the organizers that helped us through them, Eric and Nicholas and Hamidi. They were very well organized that through this past few weeks. I know you guys worked day and night, and we had pre-lecture lectures and a lot of sessions, so we are all thankful. And thank you everybody for being here. So they asked me to do case presentation. So I have a few slides that probably you've seen. Dr. Cohen used some of those slides, and you're probably familiar with the practical aspect of it. And so no further ado, these are my disclosures. What I'm presenting today is just my own ideas. It's not ideas of my employer or any other organization I'm related to. So in general, I'm going to talk about prostate cancer imaging using more popular PSMA radiotracers today, discuss some of the perils and pitfalls of PSMA imaging, and briefly or an overview of application of PSMA PET CT for staging and treatment response, and also a few slides about the AI application in our imaging. Each of those topics can be an hour talk, so I have to speak fast, so excuse my speed. I have some slide. I like to start with just this one case, and probably when I'm done, we can probably skip the rest of the talk. But this was a 75-year-old gentleman with high-risk prostate cancer and had prostatectomy with an XRT and radiation therapy and ADT, and was diagnosed 10 years back. So he had increase in PSA level to 2.81, and his conventional imaging was completely negative. So he came in with completely negative bone scan, and CAT scan was as negative. The only thing we saw was that little dot of uptake, and I think we saw is on the stomach wall. So we were not too impressed about that. So we said we can keep an eye on it. He comes back 12 months later. His PSA is rising, still bone scan completely negative, CT was negative. He had this new lesion, very small, with very faint uptake. But look at his the lesion on the stomach next to the stomach wall is beginning to start bigger, and it's really hard to miss now. But still, the CT was as negative. So we bring him back 16 months later. That lesion subdiaphragmatic next to the liver is now pretty obvious. Still, the CT was read as negative. And bone scan, when you see more lesions are showing up, and the lesion in the stomach is pretty obvious. And then 20 months later, he has multiple lesions, and bone scan was still negative. So I can rest my case with this for usefulness of PSMA and how effective it can be, and it's a game changer. And I'm really envious of new trainees that they're coming into the field at the right moment. So keep up the good work. So I think Dr. Cohen showed the slide. Some of my slides, I have to thank Dr. Kalai from UCLA. I borrowed the slides from him, and this is the structure of PSMA. And I have some of my colleagues say this is a misnomer. This is folate hydrolase 1. So they're very particular because we can use it not only in male related malignancies, but also in female malignancies. So they just want to be gender neutral. So they only use folate dehydrogenase 1. So it's, as other speakers mentioned, over 100 to 1,000 times highly expressed by prostate cancer cells. And again, maybe it's a repeat, but there are many different radioligands. The two that are circled, 18F-DCF-PYL and gallium-68 PSMA-11 are the ones that are mostly used and currently approved in the US. So I'm just going over quickly some of the pivotal clinical trial that contributed to the approval of these tracers. The OSPREY and CONDOR studies are essential studies that were performed for approval of DCF-PYL. In OSPREY, this is a comparison, thanks to Jeremy, between the OSPREY trial, which used 18F-DCF-PYL, and UCSF-UCLA trial for approval of gallium-68. And then when we look at the data, it's very comparable in terms of sensitivity, specificity, and positive and negative predictive value. And then this cohort B on OSPREY was the recurrent and M1 disease, and showed the overall a median sensitivity of 95.8% and median positive predictive value of almost 82%. And this is another comparison, thanks to Jeremy's slide, between the UCLA-UCSF study and the CONDOR in terms of recurrent disease in basically based on the PSA level. And again, we see there's very similar comparable findings in both radiotracers. This is from our colleagues in Australia, a good study, but comparing conventional imaging to PSMA. And as you see, the accuracy, sensitivity, and specificity in all of them, PSMA imaging outperforms the conventional imaging. Again, thanks to the UCLA group, they performed this study. Many of us use and maybe still are using fluciclovine. So in overall, it's a small study, but then overall showed the PSMA had the detection rate of 56% in that cohort, while fluciclovine had 26%. We started offering PSMA imaging about 2018. I guess we started with the Vision trial, and then we also explored the TLX, but then generator was very hard to find those years. But I personally actually use those compounds. That the kit is very interesting. You don't have any needles. You just connect the two and then back and forth. And we bought that little egg. It came from Belgium. It was pretty heavy. It's a nice shield, so you can do everything. And the quality control TLC is pretty straightforward. But we ended up using PYL, and this study I got all the approval just right in when we were in the middle of pandemic. So I had the decision to not to do the trial or just go ahead, and fortunately we got the exemption. All research activities were closed at the time, and we started our trial in April 2020. We got 250 subjects. It was exclusively for veterans. Some of them flew from different parts of the country to get the imaging done. And overall, we realized there was 66.2% change in management, and then the most changes were in patient in biochemical recurrence, almost 78% management change. This is also unpublished study from our work. We presented in RSNA and some other meetings, and we did a comparison between PSMA, ATN-DCF-PYL, and MRI. And in general, when you look at that table, when we're looking at pelvic lymph nodes, distant lymph nodes, and skeletal metastases in all, PSMA PET-CT outperformed MRI. But the take-home message is this is not to replace MRI, it's just a complementary study, particularly in initially diagnosed patients. This is straight from the packet insert on Pylarify with indications. I don't spend much time on these, but basically on patients who are suspected for metastases or for recurrence. And this is from, I think we have two tracers called, two names, Illuccix or Locomets. I think in the approval, FDA approval for Pluvicto, it's also approved imaging agent with it, but you can alternatively use either one. So that there's a third one, and indications, which is for selection of patients with mCRPC who are getting a lutetium-177 therapy. In terms of patient preparation, it's pretty straightforward. No fasting is needed. Of course, hydration is important, and you can follow your own protocols, very similar to other types of imaging we're doing. Image acquisition is also pretty similar to other PET-CT procedures. We started with not imaging the head, but for the sake of easier protocol for our technologists, we image everybody from head to upper thigh. If there are patients with known diseases below thigh, you can scan them even further. So this is case number 2. I use this as a normal distribution. Dr. Cohen covered that, so I'm not going to spend time on this one. As you see, there are uptakes in the salivary glands, liver, spleen, kidneys, which is the basically Achilles heels of the studies if you're looking at areas in the pelvis. Now I have a few cases. These are the patients who went through clinical trials and they got both scans with short time difference. This is one patient with 1 week earlier, got 18 FDC-FPYL and gallium-68 within 1 week. As you can see, they're pretty comparable. The images are crisper with maybe cleaner background, and that comes from the gallium difference between gallium-68 and 18F. But in general, this patient had one lesion in the spine, and as you see, it's better delineated on the 18F. But overall, in clinical practice, there's not a huge difference. What is important if you're doing both, that's our case that we do both. It's good if you start with one scanner, with one radio tracer. It's better to do the follow-up with the same one. So this is another patient. They studied on 3 months earlier with 18F, and this patient unfortunately progressed. So we see more lesions after 3 months. But again, in general, there's a little bit better resolution and cleaner background, but overall, not a whole lot of change between the two. And this patient unfortunately had widespread disease, and I think we can see that there's some difference, small differences between the two, but overall it doesn't change the clinical picture of this patient with widespread metastatic disease. So I'm going to cover some of these items in my clinical cases. PSMA aided biopsy, some initial staging, treatment response, and I'm going to finish with lutetium PSMA related imaging, but our next speaker is going to cover most of the treatment aspect. So PSMA aided biopsy is not one of the approved indications, and we had cases that either a patient had negative MRI or a negative biopsy, and they wanted to get a better idea before we do another biopsy on the patient. I just put one case, which was the extreme. This was a 70-year-old gentleman with PSA of 287, almost 288, and he had the negative MRI and 2 negative previous biopsies. And the patient was very anxious. So this was, he came and we did the PSMA, and then if you initially when you look at it, you don't see any lesions, but right below the bladder is actually the tumor. It's such a huge tumor, and you can appreciate it on the sagittal image where the arrows are. And here was the reason they missed it, is that the tumor was mostly in the anterior aspect of the prostate. So when they did the biopsy, they missed it, but the third time they got it right. And when this patient came off the scanner, I actually called him and showed him the tumor. It was probably one of the few patients that when you show them they have cancer, they have a sigh of relief, because he was living in a state of limbo for many months. That was the sad part, and that psychologically he was under a lot of pressure. But when I called him right away and showed him, he said, "This is your tumor." I said, "Oh, you found it." Some cases about staging and treatment response. This slide I put it particularly because sometimes we get the scans and we have really faint uptake in the prostate gland, and you don't know what to do with it. There are some studies, they have a cut point for SUV 4.5, but it might be too low. But don't be surprised when you image a patient, you may see multiple sites, and all of them may not be prostate cancer. So there are studies that they looked at the second lesion, and I guess at one of them I looked, they found 50% of the second lesions were not really prostate cancer. They were like inflammation, especially when you get younger patients. It may be due to inflammation or infection or other things. So it's always good to keep an eye on it, but we consult our urologist and they make the final decision if they want to go for that lesion or not. So this case is a 56-year-old gentleman with newly diagnosed, and now the targeted therapy is available. A lot of patients want to come for a PSMA scan to make sure they get the right lesion. So this patient wanted to go for a transurethral ultrasound ablation, which is called the TULSA. So we scanned him and the baseline, and the tumor was there. And unfortunately, they didn't take the whole lesion out with that with the therapy. But still, we can keep an eye on it. If he wants to go for a second therapy, he can. But that tells you that our tool is good enough to guide the targeted therapies that are becoming more and more available. The second case was another young person with high-risk prostate cancer, and he went for laser ablation, salvage therapy, and as you see the baseline, the tumor is there, and after the treatment, this one was very successful, and they took the whole lesion out, and now there's photopenic area on the right aspect of the prostate. So this case, I put it for comparison between fluciclovine and PYL. This was a 78-year-old gentleman. Incidentally, he had FDG for some other reason. I think he had a lung nodule or something, and they saw uptake in the prostate. So then he got the diagnosis, unfortunately, and then he came in. He had a fluciclovine study. So it's a side-by-side comparison between the two, and I think you're familiar with the fluciclovine. It has more background uptake in the marrow, in the muscles, and as you see, the PYL delineates more images, more lesions. And this is a side-by-side. The top row are fluciclovine, and the bottom row, as you see, as I indicated with the arrows, there are some of the lesions, like the one in the pubic symphysis and some nodes, and even inside the prostate, the PSMA imaging identified more lesions. So the same patient came for follow-up. So the baseline is actually the study tree is the baseline, and as you see, he got radiation therapy in some of the lesions, and there are less lesions, and this is the inside the prostate. Again, as we go to the through the images, the lesions are responding to the treatment. The rib lesions he had looks still pretty hot, but if I don't know if you can read the SUVs, but the original SUV max was 101, and it went down to 31 and 19, and that brings up the issue of using a standard method for comparing these studies, because once you start reading this, then the doctors will come to you. And sometimes if patients travel between centers, they may get with studies with different scanners. So it is essential that as a whole community, like worldwide, we come up with some standardized methods. And I'm going to cover some of that in my future in other slides that I have. So case number 11 was a patient with not really high risk, Gleason 6 status brachytherapy and ADT. PSA was 2.38. And first look, it seems like a negative scan, although he came with this note that was called on diagnostic CT, and the uptake was not much, but it was biopsied and it was positive. So it's not always a very hot spot. So we have to review it just like FDG, that we have this little areas of mild uptake that might be real cancer. Now I'm going to talk about some of the pitfalls. As we read more and more, I guess finding positive lesions are pretty simple on PSMA, but not overcalling, that takes a while. After maybe 30, 50, depends on what type of population you're dealing with, you get more of this. So this is not more of a pitfall, but a suggestion and the use of technology. So this patient had uptake in the left supraclavicular lesion that we should always keep an eye on it. That's an area where COVID node may be a site of, and in some patients, the only site of metastatic disease. But this was the actual image of him. So as you see, he had bilateral prostheses in the shoulders, and that would have been the case if we had not used the metal artifact reduction. So if you have it on your scanner, use it for sure. And if you're getting a new scanner, make sure you ask the vendor to provide this, because that's a lifesaver. Like this other gentleman, we get a lot of patients with hip replacement, and he had this lesion in the right groin, and we didn't know what it is, and this was just a bladder herniation. Same as this other case, another case of bladder herniation in the right inguinal canal, that the patient, if you see here, the activity doesn't continuously goes, and it was just part of bladder that had the activity, and it was an interesting case. Although we rarely see metastatic disease in the inguinal canal, but there might be other pathologies that has uptake of PSMA. And this one was a bladder diverticulum. I think the bone scan, I don't know, it looks like a ghost is standing there. It's pretty fade, but the point was, yes, you do PSMA scan, but you can always look at other studies for, and we do, at least we used to do more sodium fluoride. So sometimes if I'm not sure about the urine activity, I go back and look at other scans to see if, so definitely MDP wouldn't show a PSMA avid lesion, so it's urine activity. So like other cases we're looking, is always good to consider other imaging for troubleshooting and finding the problem. So thyroid uptake is common in some patients. Sometimes it is benign and sometimes it's not, but keep an eye on it. And if it's necessary, we can do further studies for evaluation, or just in the follow-up studies looking at it. Keep in mind that patients may have other pathologies. This patient had lymphoma, so that lymphadenopathy, that probably the conventional imaging may have called it for prostate cancer, or not sure. This didn't have uptake in PSMA, but sometimes the actual prostate cancer metastatic disease may not show uptake. So it's kind of, if needed, you need to do biopsy or follow-up imaging. Lungs are important to keep in mind, like other imaging. This patient had very low uptake in the lung, and the biopsy showed it wasn't prostate cancer. This is a twofer. So we have the celiac ganglion uptake, and based on the location, and I didn't put the CT, but it's pretty easy after one or two that you see, you recognize and won't call it. But in addition to that, both on the MIP image and the transaxial, he has a spleniole, very small one, like so it can kind of mimic lymph nodes. The stellate ganglion, pretty easy to detect based on the anatomy. You see a few and then you won't mix it. Always keep in mind to reduce the intensity and evaluate spleen and liver, because they usually have higher uptake and we may miss the activity. This patient had focal uptake in the spleen, but it stayed stable over almost 2 years. So some of these, there are case reports that they said it might be hemangiomas in the spleen, but it's always good to keep an eye on it. Similar pattern in the liver. So this patient had the PSMA scan with the focal liver uptake. The MRI was positive. It was biopsied. It was HCC. Although the uptake in the PSMA was smaller than the lesion, and then below he received the Y90 ablation, and that's the PET CT post therapy that they got the whole lesion. And of course, fractures, we're all familiar. We can easily recognize them, recognize the rib fractures or other fractures in the bone that may have PSMA uptake. So these are two of the publications. Of course, there are a lot of publications that I recommend if you want to start reading this, the ENM guidelines and also the joint ENM and SNMI procedure guidelines that can be a helpful reference for you. Now I'm going to segue to artificial intelligence. So again, I thank Jeremy for these slides. So there are some unmet clinical needs. So we need to assess progression over multiple scans, as I mentioned, and response to treatment, and the PSMA ability for the therapy, PSMA directed therapy. And the barriers is too time consuming. There's a lot of manual work involved, and then the workflow we use is not standardized. So I'm just showing one product. I know there are other vendors, they have other products, and it's based on your preference, but using AI, I don't know if you can play the movie over in the back. I don't know how to play it here. You click on it. Oh yeah, it's working. So we do the PSMA scan, and then we upload the image into the AI program, and it does the segmentation based on the CT. And the next step is the program detects that the positive lesions and excludes the normal uptake. And then it automatically estimates the uptake in the liver and blood pool, and automatically detects the anatomical hotspot labeling and quantification. And of course, always has to be reviewed by a physician to make sure there's no mistakes there. And it gives a quantitative output that you can use in your reports. And then the way it works is basically, it doesn't use the parotid gland because some scans may cut the parotid. So that's why it does twice, double uptake of the liver as a parotid, and then calculates the PROMIS score. So if you want to use the prostate molecular imaging standardized evaluation criteria, that's the criteria. So you have to do manually for all lesions. So that probably takes a long time if you have 1 or 2 lesions in the scan. But overall, it calculates that, and it gives a standardized report. And our initial report has been published in JNM in May 2021. So if you're interested, you can take a look. But it doesn't matter what product you're using. If something even you can create in-house, it might be helpful, especially for people who are starting reading the scans, and even sometimes experienced readers. I have to scratch my head and look at it. Is this the ureter uptake, and sometimes we look at the follow-up scans to just clarify. So my last few cases about imaging of prostate cancer therapy using lutetium-177. My first case in that category was a 72-year-old gentleman with high-risk prostate cancer, had radical prostatectomy, received ADT, abiraterone, and also 4 doses of radium-223 and 23 cycles of docetaxel. So that was his baseline PSMA scan with widespread disease and PSA level of 95. We do baseline FDG, and as you see that the pattern on FDG doesn't indicate a lot of uptake. It was just mostly bone marrow uptake, reactive bone marrow uptake. And then we give him 2 doses, and that's his scan after the second therapy, and his he had immediate response in PSA uptake, PSA level. And after the third therapy, PSA was 0.11. So at that point, I told the patient, you know, there are not many lesions to treat. So we stopped the treatment at that point. So we gave him some time. We scanned the patients with the gamma camera after the therapy. So that's after his first treatment. You see a lot of uptake. So that's basically can be the poor man's PET imaging. Instead of the PET, you can get this kind of images, and it is very helpful. And as you see after the second treatment, there are less uptake in the lesions. So fast forward 4 months, he comes back. His PSA, we were following him with PSA level. His PSA went up to 68.4 almost, with a lot of lesions. We gave him 2 doses of treatment, and that's his PSMA scan after therapy, and he's getting his 6th dose, I guess, in a couple of weeks. This is the opposite of that patient. So this patient, that's the PSMA scan, and the sodium fluoride, as you see, is only 1 lesion in the right femur. And it has PSMA uptake. He received, so this is his baseline PSMA. He had the FDG. There are some uptake in the FDG, but much less compared to PSMA scan. And then after 3 weeks after second dose, he had better response, and his PSA level dropped from 91 to 3.3. And we had to stop therapy for him for other reason. His ECOG status dropped. He had renal issues and some other issues that he stopped. But even with 3 treatments, last week I talked to him, and his PSA dropped to 0.4 or something, even with 3 treatments. So it can be very amazing for patients. Some of them tell me they never seen their PSA this low in years, and it's very reassuring for them. And these are his after the first, second, and third dose, the gamma images. So case number 26, I have 3 more cases to go. So this patient diagnosed in 2006 had radical prostatectomy, received ADT, abiraterone, and docetaxel. So the baseline PSMA showed some uptake in the rib. He had actually a mass there and some uptake in the liver, but unfortunately, baseline FDG was not that promising. He had a lot of disease in the liver and some lymph nodes without PSMA uptake. We gave him the first dose, and after the first dose, his baseline PSA from 896 went to 1,000. So we have to make a decision if he wants to get the second dose or not. And this gentleman had IMRT, ADT, and abiraterone, and docetaxel, and similar to that, baseline PSMA showed several lesions in the liver, but many lesions in the liver and bulky lymphadenopathy in the pelvis or retroperitoneal, and also in the chest that had FDG uptake but no PSMA. Again, we treat him, his PSA went up, and then his ECOG status dropped, and he decided not to continue the treatment. And this is an interesting case that the gentleman came in, he had exhausted all type of treatment, so the tumor board referred him for evaluation of lutetium therapy. So I don't know if from those slides you can see, the only lesion he had was in prostate bed. He had prostatectomy, and then in the right around the neck of the bladder. So very local. His PSA was low. So we we told him this is too early for therapy. So he went back to the tumor board, but they sent him back for another evaluation. And this time, we decided he may be qualified. So we did the FDG, and sure enough, in FDG, we saw a lesion in the sternum and in the rib on the right side. So we told him we have to repeat the PSMA, and sure enough, those lesions were fortunately had higher uptake on PSA, so PSMA scan, and we gave him his first dose, and as you see, he had uptake in those lesions. So we're waiting for his second treatment. And with that, am I on time, or I went too fast? Or yeah, it's end of the day, so I just don't want to keep everybody long. But I hope that this will helpful, and hopefully next meeting we have a lot of people from Canadian centers presenting cases to us. So this is a game changer. I think the benefit is mostly for the patients. They always spend a lot of time, they live with the disease. So I spend time with my patients. I like to talk to them. I encourage them to bring the family. The significant others are also very concerned. So it's good to go over either the imaging or the therapy and discuss it with the patient. Unfortunately, some of our oncology colleagues are so busy, or urologists, they just see the patient in 5 minutes and send them out. So, but we can have a good bedside manner and prove ourselves as real physicians.